Hi folks, welcome back. This is Dr. Patil here, and today we are connecting to discuss rheumatoid arthritis. Now we all recognize rheumatoid arthritis is a very important topic for entrance exam, for practice, right? For your university exams, for everything this is an important topic. Now we know rheumatoid arthritis is a systemic disease, right? So I'm calling it as a systemic disease and not a arthritic condition. It's a systemic disease predominantly affecting joints, but there is significant involvement of other organs also. Right? Okay. Now, this systemic disease is due to inflammation which has autoimmune origin. That kind of sums up what is rheumatoid arthritis. Now, without wasting time, let us talk about the epidemiology of rheumatoid arthritis, one important MCQ area. Right? So, from the very undergraduate days, we know that when we talk about rheumatoid arthritis, we should be talking about a female patient. Females are definitely more affected than males, with a ratio of various resources mentioned anywhere between 2 to 3:1, right? So that's the gender distribution ratio. But we have to also remember that some of the rheumatoid arthritis manifestations may not be very common in females. Like for example, one thing that strikes my mind is interstitial lung disease, ILD secondary to RA, right? The ILD secondary to RA is more common in males than females, right? Now, before we move on, one or two important MCQ points. ILD secondary to rheumatoid arthritis is usually UIP type of ILD. I have told this even in the regular ILD videos also. So, whenever we talk about connective tissue disorder related interstitial lung diseases, we know that most cases are NSIP type, but rheumatoid arthritis is an exception. Here it is most likely a UIP type, right? So, remember this point also. This ILD is more likely to be UIP type. So that means it's going to behave more aggressively, right? Okay. So that is one feature. Now, what do I mean by males are more affected with RA related ILD than females? It simply means, yes, females will continue to hold the major risk, but those males who develop rheumatoid arthritis are more likely to develop interstitial lung disease, right? Okay. Now, coming to the age, like age is definitely a risk factor, right? So the risk of developing rheumatoid arthritis starts increasing with every passing year after 25 years of age. Right? So from 25 to 55 years of age, the risk of developing rheumatoid arthritis keeps increasing. So at this point, it is increasing. After 55 years, right, the risk of RA plateaus, in the sense it's no longer increasing. You have a risk, but the risk is not increasing with passage of age. And after 75 years of age, the risk starts decreasing again, right? So if you plot between 25 to 55 years, the risk is increasing 25 to 55, and then it plateaus at 55, and at 75 it starts declining, right? So it is plateauing at 55, 25 onwards it is increasing, and it starts decreasing after 75, right? And the usual age of presentation, I'm talking about the population average, right? So it is around 55 years in the Western population, right, in the Western world, and it is around 33 years in India, right? So in India, the usual age of presentation is around 33 years. The median is around 33 years. Got the point? Okay. Now you should also be familiar with respect to age with one more term called LORA. LORA stands for late onset rheumatoid arthritis, right? What LORA stands for? Late onset RA. So how do you define it? The development of RA after 65 years of age is called as late onset rheumatoid arthritis. Okay. So what have we recognized so far? Female gender is a risk, age is a risk, and after 75 the risk starts declining. From 25 years onwards the risk keeps increasing, plateaus at around 55 and decreases after 75 years of age, right? Okay. Now coming to the risk factors. Now you have to take one important message home. The message is 60% of the rheumatoid arthritis risk has genetic origin, and another remainder of the risk has environmental factors contributing to that. But we have to also understand that only 5% of the RA patients have family history. Only 5% RA patients have family history. So though genetic risk is an important contributor, environmental factors play an equally important role in the pathogenesis of rheumatoid arthritis, right? Because not all those who have risk of rheumatoid arthritis go on to develop rheumatoid arthritis, right? Okay. So what are the genetic risk factors? Obviously, when we talk about genetic risk factors and rheumatological disorders, we know that we should be first talking about HLA, right? So particularly, I want you to remember two HLA variants which are associated with risk of acquiring rheumatoid arthritis. The number one is HLA DRB10401, right? HLA DRB10401, that can be summed up as DR4, and the other one is DR14, right? So please remember these 2 points. These are very, very important, right? These are extremely high risk factors for acquiring rheumatoid arthritis. And if there is an MCQ asking which one has the highest risk, which genetic variation has the highest risk, it is the HLA DR4. So presence of HLA DR4, or in other words DR4, DRB10401, carries the highest risk of rheumatoid arthritis. Okay. Apart from that, there are also certain non-HLA. Now I have to confess that I am not making a very extensive list of HLA variants associated with rheumatoid arthritis. These two are the most important points you need to remember for exam, DR4 and DR14. Okay, the other HLA variants, you will find a long list of those HLA variants in your Kelly's and other rheumatology textbooks, but I don't think those are particularly important for the NEET SS aspirants. Okay. Now, when we talk about non-HLA genetic factors, right, the first thing you will be talking about is PTPN22. PTPN22. So, where else we have spoken about PTPN22? We speak about PTPN22 in case of diabetes, mellitus, type 1, also type 2 nowadays, and then we also talk about PTPN22 in pathogenesis of SLE, right? So, SLE, diabetes mellitus, and rheumatoid arthritis, three classical disorders where PTPN22 contributes to the risk, right? Apart from that, certain polymorphic variants of STAT4 and also CTLA4, right? Now, as of now, we do use medications targeting the CTLA4 for management of rheumatoid arthritis, right? Which molecule we are talking about? Right, we are talking about, abatacept. Abatacept. Okay, so this is about the basic genetic risk factors. Okay, and now, yeah, I think I forgot to mention that there is an emerging interest about polymorphic variants of another gene called as PADI4 or PADI4, however you want to call it, PADI4. Okay, what is PADI4 stands for? PADI4 stands for peptidyl arginine deaminase, not deaminase, deaminase 4, right? So peptidyl arginine deaminase 4 enzyme, PADI4. Okay, so this is an enzyme which is involved in conversion of arginine to citrulline. So whenever there are tissue proteins, this enzyme can citrulinate. It can convert the arginine residues or arginine amino acid moieties to citrulline. And you know that, right? We have these anti-CCP antibodies which are basically targeted against citrulinated peptides. So certain polymorphic variants of PADI4 may be associated with increased risk of developing rheumatoid arthritis. Okay, so this is about genetics. Now, I have already told you environmental factors play a very, very important risk in terms of pathogenesis of rheumatoid arthritis. So let us talk about those environmental factors. Now, there are certain environmental factors which are associated with protection, and there are certain environmental factors which are associated with increased risk. So what are those factors which are associated with increased risk? The number one thing you have to remember is smoking. Smoking is the most potent, right? Please mark my words, most potent environmental risk factor for rheumatoid arthritis, right? So it increases the risk of developing rheumatoid arthritis by 21 times, 21x multiplication of the risk, right? Okay. So apart from that, having periodontitis or periodontal disease, particularly caused by an organism called as Porphyromonas gingivalis. Porphyromonas gingivalis. Okay, so this organism is peculiar because it expresses an enzyme called as PADI, right? So just now we were talking about PADI. What PADI stands for? Peptidyl arginine deaminase, right? So this actually, or PAD, this actually converts arginine residues in proteins to citrulline residues, and we know that these citrulinated proteins are the ones which are targeted by the antibodies, right? So thus it can contribute to the pathogenesis of rheumatoid arthritis, and this is the only infection where a cause-effect relation has been established. Like we do consider patients infected with Epstein-Barr virus, chlamydia, and various other infections might have some role to play in the pathogenesis, but we have not proven it, right? This is the only infection where the cause and effect relation has been established. So studies have shown that patients with periodontal disease are at increased risk of developing rheumatoid arthritis, and those where this organism has been isolated have a significantly higher risk of acquiring rheumatoid arthritis, right? Okay. Then apart from that, coffee consumption, yes, exposure to mineral oils, which is a bit common these days because often the cooking oils are contaminated with mineral oils. So that can be a contributing factor. Exposure to silica, we all know it is an immunoadjuvant, so obviously that can increase the risk of any autoimmune disorder per se. SLE, you talk about any other autoimmune disorders, and so is the case of rheumatoid arthritis. And now coming to these forgettable but important points. One is multiparity. Multiparity is a risk factor for rheumatoid arthritis. Old age at menarche is a risk factor for rheumatoid arthritis. And on the contrary, young age at menarche. Now, what do you mean by old age at menarche? More than 15 years at the time of menarche can be said to be a risk factor for development of rheumatoid arthritis, and an young age of menarche as well as oral contraceptive use. These are protective, right? And these are important MCQ points. Young age at menarche and oral contraceptive use are protective against rheumatoid arthritis. Clear? Okay. And we all know modest consumption of alcohol is obviously protective, right? So smoking is an extremely high risk factor and modest consumption of alcohol is protective. So this is about environmental factors. Important MCQ point, number 1 is this, young age at menarche. Number 2 is OCP use. These are protective. These are important MCQ points. And then Porphyromonas gingivalis, that's number 3. That can be direct MCQ. Which infection has been proven to be contributing to the pathogenesis of rheumatoid arthritis? Porphyromonas gingivalis. And then the number 4 MCQ is, what is the most potent environmental risk factor? That's obviously smoking. 21 times increased risk. Okay, and then other factors might appear in MCQs asking you which of the following is not associated with increased risk or which of the following is associated with increased risk of rheumatoid arthritis. So you need to remember all of this, right? Okay, so having said that, now let us move to the pathogenesis. Now when we talk about pathogenesis, I'll give you a quick summary of that. But before that, also remember, okay, apart from that Porphyromonas gingivalis, nowadays we talk about gut microbiota in pathogenesis of most of the rheumatological disorders, and so is the case of rheumatoid arthritis. And what has been observed is that there is some degree of gut dysbiosis. So the bacteroids in the patients who are diagnosed with rheumatoid arthritis, in their gut flora, bacteroides are decreased and there is increased count of Parvotella capri. Parvotella capri, the count is increased and bacteroids are decreased. Again, an important MCQ point for the INI-SS. Okay, now coming to the pathogenesis of rheumatoid arthritis, quite an extensive topic, and let me try to summarize it. Okay, point number 1, what kind of autoimmune disorder rheumatoid arthritis is? So in case of rheumatoid arthritis, there is a role of innate immunity as well as adaptive immunity. So there is cell mediated injury, there is antibody mediated injury. Okay, but then if there is an MCQ asking you what is the principal driver cytokine responsible for major changes in rheumatoid arthritis, right? The answer has to be TNF alpha, right? So that's why we talk about anti-TNF alpha medications whenever we talk about rheumatoid arthritis. This is the principal driver cytokine, right? Okay, so let us understand how this TNF alpha overexpression occurs in patients with rheumatoid arthritis. Okay, so obviously now we know important environmental factors, we know important genetic contributors, right? Just a quick recap. So you should know that DR4 and DR14 are risk factor, PTPN22 is a risk factor, polymorphic variations in PDE4 are risk factor, and so is CTLA4, right? So these are the important genetic risk factors. Environmental risk factors, obviously let us talk about periodontal disease. Periodontitis caused by Porphyromonas gingivalis, and apart from that you have smoking, a major contributor. You know how smoking contributes to the risk of developing rheumatoid arthritis? Smoking actually causes overexpression of PDE4 or peptide arginine deaminase. Its overexpression is stimulated by smoking. That's how the risk increases. Okay. Now all these risk factors, genetics and environmental risk factors put together, how do they cause rheumatoid arthritis? They cause rheumatoid arthritis by modifying tissue proteins. Right. So what are these modified tissue proteins? So genetic factors and environmental factors together, they alter the tissue proteins, right? The important alterations that one needs to know is, one is citrullination, right? And we have discussed this mechanism caused by the enzyme PDE4, citrullination. Okay. There are various other modifications, but two are important. Citrullination is one, and carbamylation. So these carbamylated peptides and citrullinated peptides are recognized by antigen presenting cells, which are nothing but our dendritic cells, right? So these are antigen presenting cells. So these present the antigen. These citrullinated or carbamylated or any other forms of altered proteins, these are presented to the T cells by the dendritic cells. Now, the T cells that are activated here are basically two types of T responses, Th1 response and Th17 response. So, once the Th1 cell response is activated, right, what is the end result? This leads to production of certain cytokines, interleukin 1. So, that's why we do use anti-IL-1 drugs like anakinra in the management of rheumatoid arthritis. Not commonly used these days, but it was proposed. Then we have interleukin 6, another important inflammatory cytokine. So we do use anti-IL-6 drugs like tocilizumab, right? Now we are very much familiar with this drug since the COVID era. That's an IL-6 drug, anti-IL-6 drug. So that is one more inflammatory cytokine produced by this drug. And the third one is production of interferon gamma, right? Now we know that this interferon gamma primarily stimulates or gets macrophages recruited, right? So it causes activation and recruitment of macrophages, and these macrophages produce our principal cytokine, that is our TNF alpha, right? They produce this TNF alpha. Now TNF alpha causes further important changes. I think getting into the details will be beyond the scope of our discussion, so let me get back to the point. So we now recognize TNF alpha as the principal driver cytokine, right? Okay, apart from that, there is also some contribution from the Th17 cell activation. So this produces interleukin 17, right? So this is pretty easy to remember. Th17 cells produce interleukin 17. This is also a pro-inflammatory cytokines. Okay, so that is one set of abnormalities. But obviously we talk about all these antibodies, right? So we talk about anti-CCP antibodies, anti-carbamylated peptide antibodies, we talk about RA factor. All of these are antibodies, and antibodies are obviously not going to be produced by your TNF alpha, or they are not going to be produced by your Th1 cells or Th17 cells. They are going to be produced by B cells. So how the B cell activation occurs, right? So this B cell activation occurs. Okay, so how B cell activation occurs? Now, the B cells have a specific receptors called CD40 receptors. Okay, CD40 per se, it's a receptor, and its ligand is overexpressed by activated T cells. The T cells which are activated, they have increased expression of CD40 ligand. So this CD40 ligand on T cell and CD40 molecule on B cell, they interact, and that results in the activation of B cell, and these activated B cells produce antibodies, right? These produce antibodies, and important antibodies we know include your RA factor, anti-CCP, right, and also anti-carb. Anti-carb stands for anti-carbamylated peptide antibodies, right? Okay, now let us look into what happens once all these cytokines, inflammatory cytokines, are produced and there is also antibodies produced. What happens at the level of joint? So at the level of joint, all these antigens, antibodies, they all migrate into the joint space, and the first important change we start noticing is there is proliferation of the synovial membrane, right? So there is synovial membrane hypertrophy. Synovial membrane hypertrophy. That is one change you start seeing. The second change you start seeing is immune complex deposition, right? So these antibodies produced against citrullinated or carbamylated peptides, right? So those antibodies will bind with their antigens and they become immune complexes, right? And these immune complexes initially consume a lot of complements. There is complement activation, and eventually the complements get depleted and these immune complexes start getting deposited in tissues. So a significant number of extra articular manifestations of rheumatoid arthritis are also because of the immune complex deposition, right? Okay, and now when we talk about synovial membrane hypertrophy, right, this hypertrophy is because of, like, normally the synovial membrane has around 2 to 4 cell thickness, the synovial lining is around 2 to 4 cell layer thickness. It increases up to 10 cell line thickness, right? So there is a hypertrophy or hyperplasia of the synovial membrane, and within the synovial membrane there is activation of something called as FS cells. So there are cells called MS cells and FS cells in the synovial membrane. What is MS cell? MS cell stands for macrophage like synovial cell, and FSL stands for fibroblast like synovial cells. Okay, so this fibroblast like synovial cells produces substances like matrix metalloproteinases, right? We hear them a lot of times. Now these matrix metalloproteinases are basically protein digesting enzymes which can degrade the matrix, or in other words the connective tissue, right? So these MMPs and other cytokines start eroding the bone, right? So please remember, when you talk about rheumatoid arthritis, the bone erosion is basically, we call it as marginal erosion. Marginal erosion. Okay, so what is marginal erosion? Now this is the joint that you are seeing here, and this is your joint cartilage, right? So this is your joint cartilage, but there is a bone which is divide of joint cartilage, like you see here. This bone would have been the bone that is within the joint space but divide of joint cartilage, right? So that's the most vulnerable portion. That is where this synovial hypertrophy and inflammatory cytokines start eroding into, right? So we have marginal erosion. So whenever you talk about rheumatoid arthritis causing erosive arthritis, it's mostly marginal erosion. Yes, later on the whole joint get destroyed, but mostly to begin with it is marginal erosion. Okay, and this hypertrophied synovial membrane, we call it as pannus, right? We call it as pannus. So pannus formation is characteristic of rheumatoid arthritis. And as the disease activity progresses further, the joint cartilage also get destroyed, right? And also remember, there is subchondral osteoporosis. In this zone you will start noticing osteoporosis. So this osteoporosis is because some of these cytokines cause activation of RANKL, right? So the RANKL activation is responsible for development of osteoporosis. So rheumatoid arthritis is associated with osteoporosis also. So this is the basic pathogenesis. Now to give you a summary of pathogenesis, the starting point is there are environmental risk factors, there are genetic risk factors, both come together in causing alteration in tissue proteins, right? Most important alterations are carbomylation and citrullinations. Now these citrullinated or carbomylated tissue proteins are now antigens. They are recognized by the dendritic cells, which are our principal antigen presenting cells. So these antigens are presented to the T cells, which recognize these antigens as foreign, and there is an activation of Th1 and Th17 response, right? And there is also a crosstalk between B cells using the CD40 ligand CD40, and B cells are also activated. Now B cells start producing antibodies, and T cells start producing inflammatory cytokines like TNF alpha, which are the principal driving pathogenic cytokine in rheumatoid arthritis, right? And the interplay now gets shifted to the joint, where the key change that occurs, or the earliest change you start noticing, is synovial membrane hyperplasia or hypertrophy, and that is because of the activation of macrophage like synovial cells and your fibroblast like synovial cells. And then there is erosion or the marginal erosions, and as that condition progresses, there is destruction of the joint cartilage. There is also development of osteoporosis, starts with subchondral, and then later on there can be extensive osteoporosis, and then joint destruction and joint deformities occur, right? So this is the usual pathogenic mechanism. And now if you talk about the synovial fluid analysis, what is going to show, right? So obviously rheumatoid arthritis, it's an inflammatory condition, so the synovial fluid PMNs will be more than 2000, more than 2000. Okay, so this is the quick summary of the pathogenesis of rheumatoid arthritis. Now let us talk about important antibodies that we encounter in patients with rheumatoid arthritis. We are all familiar with the Ra factor, and we know that Ra factor is not that specific, right? It can be falsely positive in various other inflammatory conditions, not only autoimmune disorders, but other inflammatory conditions, including certain infections like syphilis and all, right? So it is seen in around 75 to 80% of the patients. Now, what is this Ra factor? It is a antibody targeting against Fc fragment of IgG, right? It's an antibody targeting the Fc fragment of IgG. Now, is it an IgM antibody, IgG antibody, or IgA antibody? The fact is, yes, all three, right? There is IgM antibody produced against the Fc fragment of IgG. There is IgG antibody produced, and there is also IgA antibody produced. But most commercial tests that detect RA factor are basically trying to detect IgM against IgG, right? It's very easy to remember. IgM against IgG, right? Most commercially available tests follow this. They try to detect only IgM. Clear? Okay. Now, the other point you have to notice, it is less specific in comparison to compared to anti-CCP antibody, right? In comparison to ACPA or anti-CCP antibodies, this is less specific. So, coming to the next one, that is anti-CCP, right? So, we all know what is this antibody directed against. It is directed against citrullinated peptides, right? So, the name is anti-cyclic citrullinated peptide antibodies. So, it is seen in more than 85% of the patients. Some studies going on to say 90 to 95% of the patients are positive for anti-CCP. Okay, is it extremely specific? Yes, it is highly specific, but not 100% specific. You might see again anti-CCP antibodies occurring in other conditions and also in some subclinical RA patients where they may or may not develop rheumatoid arthritis in future. Getting the point? Okay. So more than 85% of the patients it is positive and it is more specific. Not 100%, but definitely more specific than RA factor. It's more specific than RA factor. Okay. Then these are the two new antibodies that we need to know. One is anti-CARP antibody, which stands for anti-carbomoylated peptide antibody, and you have anti-PDE4 antibody, right? So these three are given more weightage when it comes to diagnosis today in the real world practice in comparison to RA factor, because we know that it is not that specific, right? Okay, particularly you have to remember the option 3 and option 4, anti-CARP and anti-PDE4 antibodies. Now they find important use in understanding the patients who are classified or someone who presents with undifferentiated rheumatoid arthritis. I shouldn't use the word rheumatoid arthritis, undifferentiated arthritis. Whether they have a tendency to progress towards RA. Most undifferentiated, if they progress to RA only. Right? If they are positive for anti-CARP or if they are positive for anti-PDE4, then the high chances that it will metamorphose into rheumatoid arthritis in the near future. Right? Okay, so that's about the antibodies. Now, a few new antibodies that you need to know. Anti-carbomoylated I have already addressed. Apart from that, there is anti-malone dihaldehyde acetaldehyde antibodies and anti-acetaldehyde antibodies that are newly recognized. Its role in clinical practice is not well established. Maybe future holds the answer, but as of now, we have to remember basically these four and particularly these three: anti-CCP, anti-CARP, and anti-PDE4 antibodies. Right? Okay. Now, yeah, before I move on, just a quick word about what is called as subclinical rheumatoid arthritis. Okay, so what is subclinical rheumatoid arthritis? Subclinical rheumatoid arthritis patient has to satisfy certain criteria. Right? What are the criteria? Criteria number 1, there should be environmental and genetic risk factors. Right? Environmental and genetic risk factors. So when we say environmental risk factors, most important one is smoking, and when we talk about genetics, it is your HLA variants, right? Mainly HLA DR4 or maybe DR40. Okay, so that's one. Second, patient should be antibody positive, one of these three, right? We're not talking about RA anymore, so it should be anti-CCP antibody, right? Anti-CCP antibody or anti-CARP antibody or anti-PDE4 antibody, anti-CARP antibody or anti-PDE4 antibody. And the third thing is there should be evidence of subclinical inflammation. Okay, so subclinical inflammation of the joint. So I'm not talking about the obvious clinical feature, patient presenting with all deformities and all. No, we're not talking about that, right? So what is subclinical? The evidence can be in the form of elevated inflammatory markers, or evidence can be in the form of MRI evidence of subclinical erosions which are not leading to any clinical manifestations, right? And the fourth thing is clinical manifestations classical of RA should be absent, right? They should be absent. Patient can have arthralgia per se, because which is like a non-specific finding, but a characteristic RA like arthritis should be absent. Then we call it as subclinical rheumatoid arthritis. Okay, so this subclinical rheumatoid arthritis, a reasonable number of them, like more than 50% of them, will eventually go on to develop an established or a typical rheumatoid arthritis. Okay, and presence of these antibodies definitely is a risk factor, right? Anti-CARP, anti-CCP or anti-PADI4, if antibody positive, then the high chances that subclinical RA might progress to what is called as clinical RA, right? Okay, now coming to the clinical manifestations of rheumatoid arthritis, let us start with articular manifestations. So we all know that rheumatoid arthritis is basically a disease affecting small joints, right? It affects small joints more than large joints. So this is basically a polyarthritis, right? The onset may be monoarticular or onset may be oligoarticular, but eventually it evolves into a polyarticular condition, right? Onset may be monoarticular, like if there is an examiner asking you what is the earliest joint affected, it is the distal radio-ulnar joint, right? Most cases get diagnosed in the oligoarticular or polyarticular stage, and almost all cases will evolve into polyarticular stage if undiagnosed or untreated, right? Okay, so when we talk about polyarticular, obviously we're talking about 5 or more than 5 joints being affected, right? Five or more than 5 joints being affected. So in that case, it affects small joints more than large joints. Okay, that's first point. Second point is, when we talk about small joint, it is the upper limb small joints which are more affected than lower limb. So the hand small joints are more affected than your feet small joints, right? Then the symmetry is the rule, right? So the involvement is usually symmetrical. Once it gets evolved into polyarticular phase, right, there is always a symmetrical involvement in rheumatoid arthritis, right? So whenever you talk about oligoarticular or polyarticular conditions where symmetry is not routine, right, most likely you're talking about you're talking about the spondyloarthritic condition, where it's like kind of opposite of this. Large joints are more affected, right? So when you talk about spondyloarthritis, we know, right, large joints are more affected than small joints. Lower limb joints are more affected than upper limb joints, right? And they are usually asymmetric. So that way it is different, right? And then when we talk about the small joint involvement, I think we characteristically know, right? Metacarpophalangeal joints, then your proximal interphalangeal joints and your wrist joint are more affected, right? MCP, PIP and wrist joints are more affected, and there is characteristically sparing of DIP, right? Sparing of distal interphalangeal joints. So if there is a small joint disorder where DIP is involved, I think only two conditions come to our mind, right? The number one, DIP involvement, number one that comes to our mind is nodular form of osteoarthritis, and second, psoriatic arthritis, right? So for DIP, we have to remember these two conditions: psoriatic arthritis and osteoarthritis, the nodular form of osteoarthritis, where patients present with Bouchard's nodes and Heberden's nodes, that form of osteoarthritis, right? Now, around 10% of the patients of rheumatoid arthritis, there may be involvement of DIP, but most authorities believe that this DIP involvement is because of the co-occurrence of osteoarthritis. Rheumatoid arthritis is a risk factor for osteoarthritis also, right? So I hope you got the point. Okay, so that's about the joint involvement. Yes, lower limb joint can also be involved, right? Lower limb joints can also be involved, basically affecting the metatarsophalangeal joints, right? Metatarsophalangeal joints are typically affected in rheumatoid arthritis. But obviously the lower limb joint involvement is a late manifestation and less common affected than upper limb joints. And these upper limb joint involvement can lead to various deformities, and so is the lower limb joint involvement, right? So patients can have flat foot because of the lower limb joint involvement. Okay, but the drama is all in the upper limb joint involvement. So let us see some important deformities, right? The first deformity we will be talking about is what is called as zigzag deformity. We know that this is the earliest, and obviously being earliest, this is also the most common deformity that we see in patients with rheumatoid arthritis. So what happens in zigzag deformity? As you can see from the image, right, there is ulnar deviation or ulnar subluxation of metacarpophalangeal joints, right? So ulnar subluxation or ulnar deviation of metacarpophalangeal joints, and there is a radial deviation of wrist joint, right? So the wrist joint is moved radially and the metacarpophalangeal joints are moved in the ulnar side, right? So this is what is called as zigzag deformity. This is not a true deformity, right? So this is a correctable deformity. This is not because of the bone erosions. It's not a true deformity. It's not because of the joint destruction, right? It is because of the soft tissue dysfunction or the tendons and cartilage dysfunction which is responsible. So this is a correctable deformity, right? Okay, so that is the deformity number 1. Now the second deformity we are talking about is what is called as piano key deformity. As you can see from the image, you will notice that the styloid process and the ulnar head, right? The ulnar styloid and the ulnar head have become prominent, right? This prominence is because of the injury to or the rupture of extensor carpi ulnaris tendon, right? This is an MCQ point I want you to remember, particularly if you are preparing for INISS rheumatology. This question has been asked multiple times. So this piano key deformity is due to injury to extensor carpi ulnaris tendon. What is this piano key deformity, right? So your ulnar styloid, because of this tendon dysfunction, right, it becomes prominent, but it is a reducible change. So you'll be able to compress it back to its location and it pops back again like your keys of the piano. That's why it's called as piano key deformity, right? That's the second deformity. Now the third deformity that we need to know, and classically we are all familiar with this, is swan neck deformity, right? So what is the change that we see in swan neck deformity? In swan neck deformity, if you look at the proximal interphalangeal joint, there is extension, right? So at the proximal interphalangeal joint, there is extension and there is flexion at the distal interphalangeal joint, right? So this is what is called as swan neck deformity. So it looks like, kind of looks like the neck of a swan, right? If you look at the swan, you will notice that the neck is always flexed. So that way you can remember, right? The distal most portion is flexed. So DIP is flexed and PIP is extended. This is what is called as swan neck deformity. Then we have one more deformity which is like exactly opposite of your swan neck deformity, what we call as Botonius deformity, right? So what is Botonius deformity, or this is also called as buttonhole deformity. Now what is this? It's exactly opposite of your swan neck, right? So what we see here, we see extension of your proximal extension of your distal interphalangeal joint, right, and flexion of the proximal interphalangeal joint. So in case of swan neck, we had seen extension of PIP and flexion of DIP. So here it is flexion of PIP and extension of DIP. We call it as Botonius deformity or buttonhole deformity, right? Okay. Now moving on, we also come across one more upper limb deformity called as Z deformity. What is this Z deformity? So in Z deformity, at the metacarpophalangeal joint of the thumb, right? Z deformity is particularly about thumb. And often students end up getting confused between the Z deformity and zigzag deformity. The zigzag deformity is your ulnar deviation of MCP and radial deviation of the wrist joint. Right? The Z deformity is with respect to thumb, right? So you can notice here there is a flexion at metacarpophalangeal joint and there is extension at interphalangeal joint. So we have only one interphalangeal joint, so we don't call it as proximal or distal in case of thumb. There is only one, right? So that interphalangeal joint, there is extension. So this is often called as hitchhiker's thumb, right? Hitchhiker's thumb. Right? Who are hitchhikers? The ones who take rides in others' vehicles, right, when they are traveling. Like now, I first came across the word hitchhiker in like few years back when I started following certain YouTube channels. Right? We call it as hitchhiker's thumb. So when you want someone to drop you off at some place, you ask like this, right? So this thumb kind of assumes that shape, hitchhiker's thumb. Okay, so these are the important deformities we need to know. Okay, now if you open up any rheumatology textbook, you will come across n number of deformities. I have not come across any MCQ per se where they had asked deformity or the underlying anatomical mechanisms behind that in any of the NEET SS examination. So I don't consider that as a very high yield exercise. So I've only covered the most commonly asked deformities. Okay, so from there now let us move on to extra-articular manifestations. So when we talk about extra-articular manifestation, first eyes come to our mind. So in case of rheumatoid arthritis, right, one standard MCQ template is what is the most common manifestation of a particular organ system. Like they might ask you what is the most common manifestation of CVS involvement in RA, what is the most common manifestation of hematological involvement in RA. So we have to first note the most common, right? So when we are talking about eye, obviously when I say most common, it is the SICA, secondary Sjogren's or SICA syndrome, right? Secondary Sjogren's or SICA syndrome is the most common eye manifestation. So patients often might present with grittiness and dryness of the eyes. That could be the presenting complaint with respect to eye. Okay. Apart from that, there can be episcleritis and there can be scleritis, right? So remember, this episcleritis is a painless redness of eyes, painless redness of eyes. On the other hand, right, and when patients present with episcleritis, right, most likely you will be able to treat them with topical NSAIDs or maybe steroids. Okay. On the other hand, scleritis is more aggressive disorder and one of the important cause for blindness in rheumatoid arthritis patients. So scleritis, it's more aggressive. It is a painful redness of the eyes. Painful redness of the eyes, and these patients can cause perforation of the sclera. Right? This can cause perforation of the sclera, and blindness is a possible outcome. And we have to remember that whenever there is scleritis, right, this needs systemic treatment. Steroids are the mainstay of treatment. You can use other immunosuppressants, but definitely systemic. Topical medications alone may not work, right? Need systemic treatment. Obviously, ophthalmologists are the best person to decide when to offer topical or when to offer systemic. But roughly, we should understand if scleritis is what you're thinking of, most likely patient will require a systemic treatment, right? Okay, so these are the ophthalmological manifestation. Important take-home message is the most commonly involved or most common manifestation of the eye involvement in RA is SICA syndrome. Okay, now next in queue is hematological manifestation. So as I've already told you, first point, what is the most common manifestation, right? What is the most common manifestation? Obviously, most common manifestation is anemia of chronic disease. Just like any other rheumatological disorder, anemia of chronic disease is the most common manifestations. Apart from that, yes, patients with RA are also prone to develop hemolysis, but less common, right? Anemia of chronic disease is the most common manifestation. And we also have this condition called as Feltes syndrome, right? So what is Feltes syndrome? Patients of rheumatoid arthritis developing, so it's a combination of RA plus splenomegaly plus neutropenia. One more manifestation of the hematological involvement. It's splenomegaly, neutropenia, and rheumatoid arthritis is what is called as Feltes syndrome. So these are the two important MCQ points I want you to remember. Okay. Now moving on to the next organ system involved, that is pulmonary. I've already told you two important MCQ points. One is one of the pulmonary manifestation, that is interstitial lung disease. That is particularly more common in male RA patients than female RA patients. Otherwise, generally when we talk about RA, females are more affected than males. So most other manifestations are more common in females than males, right? Okay, but is ILD the most common manifestation? No. Most common manifestation is pleuritis. Pleuritis is the most common manifestation, either with or without pleural effusion. And when there is a development of pleural effusion in rheumatoid arthritis, we have to note that it is a exudative type of effusion. It is not, it is an exudative type of effusion. It is not transudative, right? So one has to make a note of this. And RA, rheumatoid arthritis, is often associated with low glucose levels, right? The glucose level in the fluid, if there is pleural effusion, will be reduced, right? There will be low glucose levels. Okay, now coming to the interstitial lung disease. I have already told you ILD in rheumatoid arthritis more common in males than females. That's one point to take home. And second is most likely it is UIP pattern, usual interstitial pneumonia pattern, and that means that the disease is going to be more aggressive. Right? This is going to behave more like the idiopathic pulmonary fibrosis, right? So from the ILD modules, you would have already learned that generally speaking, connective tissue disorder related interstitial lung diseases have better outcome or better prognosis in comparison to idiopathic pulmonary fibrosis. But RA essentially behaves like idiopathic pulmonary fibrosis, right? So RA ILD is almost similar to IPF. So the prognosis is going to be bad in comparison to, let me say, SLE patient developing ILD or any other connective tissue disorder, autoimmune connective tissue disorder patient developing ILD. In those cases, this will be more aggressive. Okay. And then we are also familiar with this one more pulmonary manifestation called Kaplan syndrome, right? So what is Kaplan syndrome? Kaplan syndrome is a typical combination of pneumoconiosis, any pneumoconiosis for that matter, but particularly two pneumoconiosis are more strongly associated with RA. That is your silicosis. Now we know the importance of silica in pathogenesis of RA, right? It's a immunoadjuvant, and Kohl-Werkers pneumoconiosis. These two pneumoconiosis are typically associated with RA. The reason for Kohl-Werkers pneumoconiosis and its association with RA is again silica itself. So coal is an important source of silica. Now today we do believe that some of the manifestation, at least some of the manifestation of Kohl-Werkers pneumoconiosis are because of the presence of silica or silica exposure itself. That's why Kohl-Werkers pneumoconiosis and silicosis behave similarly, right? Okay, so pneumoconiosis plus rheumatoid arthritis plus rheumatoid nodules. Rheumatoid nodules. Right? This combination is called as Kaplan syndrome, right? Okay, so these are the pulmonary manifestations of rheumatoid arthritis. Now coming to the cardiovascular manifestation, right? As usual, let us first address what is the most common cardiovascular manifestation. So the most common cardiovascular manifestation is, right, pericarditis, right? So it is cirrhosis, generally speaking. You talk about pleuritis, right? You talk about the respiratory system, it's pleuritis. You talk about cardiovascular system, it is pericarditis. The involvement of other areas can occur. Patients can have myocarditis or endocarditis, but it's exceedingly rare, right? So it is usually pericarditis with or without effusion. With or without effusion, right? Okay. The second point I want you to note is there is increased risk of premature, right, atherosclerotic coronary vascular disease, and thus it's an important contributor to mortality, right? So there is increased CV mortality in patients with rheumatoid arthritis to the tune of 2 to 3 times the general population, right? Okay, so that's about the cardiovascular manifestations. Now moving on to the skin manifestation, right? There are numerous skin manifestations associated with rheumatoid arthritis, but for a NEET as a student, only thing that you need to remember is rheumatoid nodules. Now, what are these rheumatoid nodules? These are painless, right? Number one point to note is these are painless nodules which are subcutaneous, right? Second point is these are subcutaneous. Okay, are these freely mobile? They can be, right? Most often they are freely mobile because these are in the subcutaneous plane. They are freely mobile, but as the disease advances, they can become adhere. They can adhere to underlying structures as the disease advances, and on palpation they are firm in consistency. They are usually firm in consistency. And if there is an MCQ asking you what is the most common site, mostly they occur on the extensor surfaces, mostly on the extensor aspects of the joint. So obviously the most common site is on the extensor aspect of your elbow joint, right, overlying your olecranon bursa. Overlying your olecranon bursa. So that's the most common site. This is one important MCQ point I want you to remember, right? Now all these points you need to remember because there can be an MCQ asking you which of the following is false about rheumatoid nodule, right? Rheumatoid nodules are painless, they are subcutaneous, they are usually freely mobile, but if they are fixed, it doesn't rule out rheumatoid nodule. So they are freely mobile, but they can be fixed if the disease activity gets advanced further. And on palpation, they are firm in consistency, right? Painless is one word which is often twisted in MCQ, so please remember that. Okay, so that kind of completes our clinical manifestations, and that brings us to the diagnosis of rheumatoid arthritis. So you will consider diagnosis of rheumatoid arthritis in any female, and for that matter even males, of a middle-aged group presenting with polyarthritis involving small joints, particularly upper limb or small joint of the hands, right? That is where you will start thinking of rheumatoid arthritis. Right. Now, what I am projecting here is the classification criteria that was proposed in 2010 by ACR Euler. Now, as of now, that is the latest update, right? So in 2021, there were specific management guidelines updated, but the classification criteria remains same because it has been found that in studies that it is quite sensitive, right? It is sensitive for early detection of rheumatoid arthritis, so it is a guiding principle. But like we all know, it is the classification criteria. We are not bound to follow this for the diagnosis, but because it's highly sensitive, right? Most of us lean onto it. We kind of depend on it for early diagnosis of rheumatoid arthritis. So let us see what are their inclusions in the ACR-EULAR classification criteria. So there are 4 domains in this classification criteria, and if patient scores 6 or more than 6 points, 6 or more than 6 points out of the 10 possible points, then we will call it as a definitive rheumatoid arthritis. Right? So that qualifies for the patients to be included in clinical trials, but it also helps you in diagnosis, right? So there are 4 domains. Let us see those domains. So the domain number 1 is the joint involvement. Like we all know, we're basically looking at tender swollen joints, right? So we are talking about rheumatoid arthritis, and when we talk about rheumatoid arthritis, we know that it's a inflammatory arthritis, right? So I think I forgot to tell you about this. I've already addressed this point in the approach to rheumatology video, but just a quick recap. Right? We're talking about inflammatory arthritis. So in that case, the patient will have joint pain that is worse on rest and gets better with movement, right? Better with movement. This is exactly in opposite of your degenerative joint disease or non-inflammatory arthritis like osteoarthritis, where rest relieves the pain and movement increases the pain, right? And the second thing is the inflammatory arthritis, as in case of RA, is associated with early morning stiffness. Early morning stiffness is because of a phenomenon called as gelling. More of that I have discussed in the other video. Now, this early morning stiffness can also occur in degenerative joint disease or non-inflammatory arthritis. But in case of inflammatory arthritis like RA, it is usually lasting for more than 30 minutes. That is usually what is required for diagnosis. But in most cases of RA, it lasts for more than 1 hour, right? So more than 30 minutes classically defines it as a inflammatory arthritis. But as I told you, in most RA cases, it lasts for more than 1 hour, right? So a RA patient generally feels that his mornings are extremely worse, the joints are stiff, there is severe pain, and as the day advances, the stiffness of the joint reduces, he starts moving his affected joints, and the pain starts getting better. So his evenings are relatively better than their mornings, and the vice versa is true for osteoarthritis, right? Okay, and we have already learned that this inflammatory arthritis manifestation on examination will be associated with the joints which are tender and swollen, right? Tender and swollen. So when I was talking about subclinical rheumatoid arthritis, I think I forgot to mention you that this objective evidence of arthritis means tender and swollen joints, which you don't see in subclinical arthritis. Patient might have arthralgia, as I've already told you, right? So we are counting at these tender and swollen joints for the classification criteria. When we say joint involvement, we are basically looking at tender and swollen joints, right? How many of them are there, whether it is large or small joints. So if there is only one large joint involved, that means what? It is suggestive of a monoarticular presentation. So if it is a monoarticular inflammatory arthritis, what are the differentials that should come to our mind first? RA can be monoarticular in origin, but as I've already told you, most cases it is oligoarticular or polyarticular. Even if the onset is mono or oligo, eventually it will become poly, right? So the important differential for mono are your septic arthritis. I'm talking about inflammatory forms, right? I'm not talking about degenerative or non-inflammatory forms. So septic arthritis is one, and your crystal deposition disease like your gout or pseudo gout, right? So obviously then that would go against the diagnosis of rheumatoid arthritis, or at least not favor the diagnosis of rheumatoid arthritis. So you are giving a score of 0, right? And if there are 2 to 10 large joints involvement, the involvement of large joint is a late manifestation of RA. So if there are multiple joints involved, polyarticular picture, but large joints that are involved, then you are giving a score of 1, right? And if there is 1 to 3 small joints involved, with or without the involvement of large joints, you give a score of 2. And if there are 4 to 10 small joints involved, you give a score of 3. And more than 10 joints overall involved, right? So 2 to 10 large joints involved, all large, 1 score. And more than 10 joints involved, a mix of large, small, or all large, right? Of that, which at least one should be a small joint, you are giving a score of 5, right? So this score of 5 bring this patient very close to the diagnosis of rheumatoid arthritis, or at least classification into rheumatoid arthritis, right? Okay, so this is one domain. And then the next domain is serology. So what is the serology we're talking about? Yes, I told you that RA factor we don't give weightage, but The classification criteria was proposed in 2010, so there is still weightage given to RA factor. So if there is a negative RA and negative ACPA, that is anti-cyclic citrullinated peptide antibody, 0 score. If both or any of them are positive, but the positivity is low positivity, you give a score of 2, and if they are high titer positivity, you will give a score of 3. That is about serology. Basically speaking, antibodies, low titers, 2 points, high titers, 3 points, right? Then we look at the inflammatory markers, right? Inflammatory markers. So what are the inflammatory markers? We are looking at CRP and ESR, right? If they are normal, 0 score. If they are abnormal or elevated, you give a score of 1. And the last domain is duration of symptoms. Now, rheumatoid arthritis is basically a chronic arthritic, right? It's a chronic polyarthritic condition. So in case of joint involvement or arthritis, chronicity is defined by involvement for more than 6 weeks. So in this case, if it is more than 6 weeks duration, that favors the diagnosis of RA. So you are giving 1 point. If it is less than 6 weeks duration, then as of now, it is premature to say whether it is likely to be RA or not. So you are giving a score of 0, right? So when all cumulative score is 6 or more than 6, you will call it as, you will classify the case as definitive RA, right? And we have to also remember that patient should have at least one joint with a clinical synovitis, right? Because like if you remember from the pathogenesis section, we learned that there is synovial membrane involvement, synovial inflammation, synovial hypertrophy or hyperplasia, and then eventually the other changes are occurring. So there should be at least one joint with clinical synovitis, and with the synovitis not better explained by other disease. So if there is only one joint which is evidently suggestive of synovitis and you don't have any other explanation, only then you think of, right? So if you have alternative explanation for that synovitis, then probably you don't count, right? Clear? So this is the classification criteria for rheumatoid arthritis. So now we know how we classify a case as rheumatoid arthritis. And in clinical practice, yes, if you have suspicion, if typical clinical presentation, antibody is positive, probably you don't need to satisfy this classification criteria for diagnosing the case as RA, right? Okay. Now coming to the management of rheumatoid arthritis. What are the drugs in our armamentarium? Right, we have 3 classes of drugs. Obviously, you do consider using NSAIDs and steroids, right? NSAIDs and steroids. They are like NSAIDs, you can use them whenever required for optimal pain control. And steroids, they continue to be the controversial figures, like use of intra-articular steroids. Some studies show that it may be beneficial in the active joint. Some studies refute the findings. But yeah, one thing we can agree that steroids don't find a great role when it comes to management of rheumatoid arthritis, right? So most guidelines recommend if you are using, try to taper it off. Don't use it for chronically, or like the 2021 ACR recommendation says, do not, if at all you are using, do not use it for more than 3 months, because this steroid has a profound impact on the bone health, osteoporosis that steroids cause, and we know RA is also a condition which causes osteoporosis. So the risk of osteoporotic fractures and other complications definitely outweigh the benefits. And we all agree that steroids do not have a major disease modifying role when it comes to rheumatoid arthritis, right? Okay, so where does it have a role? As such, frankly speaking, it doesn't have a role, so we should avoid using it. And the best thing to manage a rheumatoid arthritis patient is using a disease modifying anti-rheumatoid drugs. So when it comes to DMARDs, we can categorize them into 3 broad classes, right? Class number 1, which we learned in our undergraduate days, that is CS-DMARD. CS stands for conventional DMARDs, right? So there are 4 important conventional DMARDs I want you to remember, right? Number 1 is methotrexate. Number 2 is leflunomide. Okay. Number 3 is your sulfasalazine. And number 4 is hydroxychloroquine. Right? We will discuss about the choices later. For now, remember these 4 are US FDA approved conventional DMARDs. The gold and other DMARDs are no longer in practice, right? We don't use it anymore. So these 4 you have to remember: methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. Okay, so the second class of DMARDs we are talking about is B-DMARDs, or B here stands for biological, right? So CS here standard for conventional, B here stands for biologicals. So biologicals, you can divide them into anti-TNF alpha drugs, CTLA4 drugs, anti-IL6 drugs, and anti-CD20 drugs. These are the 4 major classes of biologicals, and there are individual drugs that I want you to remember under these categories which are US FDA approved, right? Okay, and then we have this TS-DMARDs, which stands for, TS here stands for targeted synthetic, right? So biologicals are also targeted, but they are biologicals, targeted synthetic or synthesized disease modifying antibodies. So basically most of them belong to the JAK inhibitors category. They inhibit the JAK3 molecules, right? So basically they are JAK3 inhibitors. So among the JAK3 inhibitors, the newest one is upadacitinib. Okay, then we have baricitinib, and we have tofacitinib, right? Tofacitinib. These are the three important JAK3 inhibitors I want you to remember, or the targeted synthetic DMARDs. And coming to biologicals, right? Anti-TNF, we are all familiar with long list of drugs like infliximab, adalimumab, golimumab, right? Then certolizumab, so long list, right? Then CTLA4, only one drug I want you to remember, abatacept, right? And anti-IL-6, I think the first thing that comes to our mind is, you guys should know better, COVID times, right? We are talking about tocilizumab, and another USA FDA approved drug is tocilizumab and sarilumab, right? So remember that. And anti-CD20, obviously, most beloved drug, rituximab, right? So all the drugs that I mentioned here are US FDA approved. Your pharmacology books or your standard medicine textbooks will be able to talk about a lot more of these drugs, but these are the bare minimums that you need to remember, right? 4 conventional DMARDs, methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. Then some important anti-TNF alpha agents like adalimumab, golimumab, certolizumab, and infliximab, right? And for the CTLA4, abatacept, anti-IL-6, tocilizumab and sarilumab, and anti-CD20 is your rituximab, right? Now, how do we decide what to use, right? So for that, we have to understand some important points. Okay, so this is one statement I want you to remember. The statement is, the maximum joint destruction, right? Maximum joint destruction occurs within first 2 years of RA, within first 2 years of RA, right? So if there is an onset of RA in 2020, by 2022, maximum joint destruction would have occurred. Major deformities would have started appearing. So after that, right, the disease activity loses fire, right? The fire is extinguished and there is low level disease activity persisting. So if at all you need to act, and if you want to have an impact on patient's quality of life, you don't want the patient to develop deformities, right? This is the time, right? This is the time, first 2 years of life, 2 years of RA disease activity. So this is the time, right? So that means we have to be more aggressive in treating rheumatoid arthritis initially, and maybe we can step down on aggression later, right? Most of the authorities recommend that a case of rheumatoid arthritis is better managed by a rheumatologist rather than any other professional, right? So rheumatologists are the better people to manage this disorder, right? Okay, now to achieve this goal of having a absolute control on the disease activity in the first 2 to 4 years of life, right? 4 years of rheumatoid arthritis, there are specific guidelines, and what I am presenting today is American College of Rheumatology 2021 recommendations. This has certain deviations from the 21st edition, a newly launched edition of Harrison. Okay, I'll address those points. Okay, so point number 1 is, we are following a treat to target approach. Treat to target approach. So rather than just managing it conventionally, right, have some set goals or targets and try to achieve that. So what is the target, right? So target, there are 2 possible targets. One is remission, or the second one is low disease activity. Low disease activity, right? So this is our target. Now how do we achieve? With medications. When do we achieve? I'll come to that point. Right now, one important point I want you to note is the current ACR 2021 recommendations, right, talk a lot about low disease activity and they do not talk much about remission. So that basically means like remission may be too much to ask for. So they are mostly focusing on low disease activity, right? Achieve low disease activity if remission is not possible. That is the stand taken by ACR 2021 recommendation. But the Indian Rheumatology Association favors the goal as remission, right? You can go for and aim for remission, and if done by an expert rheumatologist, remission is achievable in almost, I can say, more than 90% of the cases. You will be able to achieve remission, right? Okay, so let us address what is remission. So ACR and EULAR definition of remission goes like this. You can say patient is under remission if all of the following criteria are met, right? So the tender joint count is less than 1 or less than 1, right? The joints which are tender, patient should have 1 or 0 tender joints. Then the swollen joint count, that should also be 1 or less than 1, right? So 2 points. Then the patient's CRP should be less than 1 milligrams per deciliter. So they should be like joint counts is reduced, but there should not be also evidence of inflammatory activity in the form of raised CRP, right? And then we have this thing called as physician global assessment, and then we also have this patient global assessment. So on a scale of 0 to 10, right, how good the physician feels the patient is doing, like 6, 7 or 8, or how good the patient feels he is doing on a scale of 0 to 10. So patient's global assessment is part of the definition for remission of rheumatoid arthritis, right? So that should be patient's global assessment score should be less than or equal to 1, right? All of these should be satisfied to call this case as having remission, right? Or alternatively, if you don't want to follow this, and if you are following the scoring systems for assessing the disease activity, like there are so many scoring systems which you should be aware about. There is one called as DAS 28. This question was once in, I think, PGI, asking you DAS 28 scoring system is used for which of the following diseases. As simple as that, it is rheumatoid arthritis. Or you can also use what is called as CDAI, Clinical Disease Activity Index, or most commonly used one is SDAI, which stands for Simplified Disease Activity Index. So if you're following SDAI, right, remission is defined as a score of less than or equal to 3.3. So if your score is less than or equal to 3.3 on SDAI, you can say the patient is under remission, right? So this can be our goal. If you're not able to achieve that, then if you are following the disease activity scores, then the low disease activity will be our goal. So to achieve this low disease activity, we have to remember that we have phases of treatment. So in phase 1 treatment, just like when I spoke about SLE, right, I said hydroxychloroquine is a blanket treatment for all SLE patients. We can kind of relate to that in rheumatoid arthritis. So what is a blanket treatment here? Methotrexate, right? Methotrexate. So this is considered as the drug of choice when it comes to rheumatoid arthritis. Okay, but I did make a statement saying that the current edition of Harrison in its wordings differs a little bit from your ACR recommendation. So what ACR recommends is American College of Rheumatology 2021 recommends that methotrexate monotherapy, right, is preferred over combination therapy or biological DMA RDs to start with, right? So for all cases, you start with methotrexate monotherapy, that's what ACR recommends, and titrate to the maximal tolerable dose, right? So even after optimal dose, if the disease activity is not controlled, you can think of stepping up the medication. That's the ACR recommendation, right? But Harrison also mentions conventionally or alternatively, you can think of dual treatment. What dual treatment he talks about? He talks about methotrexate plus other conventional DMARDs, right? Maybe sulfasalazine or leflunomide. And he also talks about triple treatment. So triple treatment basically means patient getting hydroxychloroquine plus sulfasalazine, okay, plus one of these two, right? Either methotrexate or leflunomide. This is called as triple treatment. So see, one thing we understand clearly, that the first 2 years are the most important time. So if at all you want to have a good achievement of remission in the shortest possible time, then Harrison says you might be able to achieve that with dual drugs or triple drugs better. But ACR says, right, taking into account the cost of medications and the other parameters and some studies, it is clear that the better approach is to keep escalating the methotrexate dose to achieve the remission. You're getting the point? So methotrexate monotherapy at optimal dose is the best way to go forward. If methotrexate fails to achieve the targets, right? So the targets are defined as, so your first assessment is going to occur within 3 months. So at 3 months, the expectation is in the form of improvement. So you started methotrexate, you assessed SDI or DAS28 or CDI, and you know the score, disease activity score. So within 3 months, you will do the next assessment after initiating the methotrexate. And at this point of time, you are expecting improvement, not remission is still not a possible goal in most cases at this point of time. So you're expecting improvement. So whatever was the disease activity score, let me say, let me just give you a hypothetical number. Let me say it was 6. Now it should come down to something lesser than that, right? So then you can say improvement. If improvement is not achieved at the end of 3 months, then you are thinking of switching over or adding other DMARDs. Right? Again, how we make a choice, I'll talk about it. Okay. And if there is improvement achieved, right? If improvement is there, then you will continue the treatment for 3 more months. So at the end of 6 months or within 6 months, we are expecting remission, right? Remission, if not possible, significant low disease activity. Right? So if given a choice, I would like to go with remission. So at the end of 6 months, if remission is not achieved, you are progressing to the phase 2 treatment, right? So let me put a simple summary of it. So basically, patient diagnosed with rheumatoid arthritis, you start with phase 1 treatment in the form of methotrexate, right? And then at the end of 3 months, if patient has shown no improvement, right? If there is no improvement, you are switching to phase 2 treatment, right? If there is improvement present, then you are continuing for total of 6 months or 3 more months, and at this point of time you are expecting remission, right? So if patient has achieved remission, then you will continue those medication, and later on you can think of, right, 2 follow-up periods if patient is having low disease activity, right? Usually spread across 3 months, right? So one follow-up 3 months after the complete remission, another follow-up 3 more months later, like 6 months later. So if these 2 follow-up periods, patient maintains the remission state and there are inflammatory markers which are well under control, right? In that situation, you can think of tapering the medication. Most practitioners would prefer to have a good control for first 2 years because that's the damaging period. After that, we think of tapering. But most guidelines talk about after achieving remission, if the patient remains in remission for 2 follow-up periods, like around 6 months, you can think of tapering the medication, right? Okay, if there is no remission at the end of 6 months, then you go to phase 2 treatment again. So at the end of 3 months, no improvement, you switch to phase 2 treatment. At the end of 6 months, those who had shown improvement at 3 months, if they have not achieved remission, you switch to phase 2 treatment. So what we do in phase 2 treatment, right? So let us talk about the phase 2 treatment. So in phase 2, basically what we do is, we at our disposal, we have conventional DMARDs which we had not used in the first place, right? So if you're going by the traditional ACR recommendation, then you would have only started methotrexate or as an alternative to methotrexate. I forgot to tell you, if there is contraindication to methotrexate, mostly we prefer using what? If there is contraindication to methotrexate, we prefer using sulfasalazine, right? Sulfasalazine or leflunomide. Right? So if there's a contraindication, we can use this. Otherwise, methotrexate remains the most important drug. So if you had not started with, if you had started with methotrexate, you still have leflunomide, hydroxychloroquine, or sulfasalazine in your armamentarium. If you had started with leflunomide, you have the other 3 drugs in your armamentarium. So that is one thing you have. Then you have biological DMARD still at your disposal, and you also have your targeted synthetic DMARDs or JAK3 inhibitors still at your disposal. Now, how do we choose which one to follow at this point of time, right? So that depends on presence or absence of prognostically favorable factors. Prognostically favorable or unfavorable factors. If prognostically unfavorable factors are present, right? If they are present, you will think of starting with either biological DMARDs or you will think of starting with TSDMARDs. Okay. And if they are absent, right? If they are absent, then you will think of starting the patient on conventional DMARDs, right? So methotrexate, generally recommendation is continue with methotrexate at this point of time and add the second agent. Like if you had started with methotrexate, now you can add, let me say, leflunomide or hydroxychloroquine or sulfasalazine. Any of these can be added, right? Or at this point of time, maybe you can think of triple therapy, right? But triple therapy as a starting point is not what American College of Rheumatology 2021 guidelines recommend. Okay. Now, what are those unfavorable factors, right? You may question me, right? So if patient is having very high disease activity, very high disease activity, or if like on the scoring systems, right? Or if there is evidence of early joint erosions, right? So what investigations you can do for the early joint erosions? Basically, you can do the ultrasound, you can do X-ray, or you can do MRI or CT if there is evidence of the early joint erosions. That's a prognostically unfavorable factor. Or if there are high antibody titers, like your RA factor or your anti-CCP, the titers are high. Like RA factor per se doesn't correlate that with disease activity, but most guidelines do recommend this. Like if you have high antibody titer, you can consider it as a prognostically unfavorable situation. So in a phase 2 trial failure cases, right, if there are prognostically unfavorable factors present, like the disease activity score is staggeringly high, or a patient has some evidence of joint erosions on ultrasound or MRI, or maybe even on X-ray, or patient's titers of antibodies are extremely high, right? In those cases, you will start with either biologicals or targeted synthetic DMARDs. If these things are absent, right, then you can play with the conventional DMARDs. You can add 2 drugs or 3 drugs. You can make it a triple drug regimen or a dual drug regimen, and you can continue treatment. Now, what is the next step? So let me say hypothetically, you got a patient where there were no unfavorable factors, but unfortunately, methotrexate alone was not sufficient to achieve the remission or a low disease activity. In that case, like let me say you added sulfasalazine, so you're now treating with methotrexate and sulfasalazine, or instead let me say you went ahead with a triple therapy. Now how do you monitor further, right? So you're repeating the same cycle that we did in the phase 1, right? So after this also, our goal is at 3 months of initiation of the new class of drugs, you are expecting improvement, right? You're getting the point. And at 6 months, you are expecting remission or low disease activity, right? If these targets, right, this is the principle of treat to target. If these targets are not achieved, you are switching to phase 3 treatment. What do we do in phase 3? Phase 3 mostly relies on biologicals or targeted synthetic DMARDs, and in phase 3 it's a little bit of trial and error approach. It's like, okay, for example, if you started with, let me say, TNF alpha blocking drugs and you still have not achieved the improvement at 3 months, or you achieved improvement at 3 months and you continued medications and you have not achieved remission at 6 months or low disease activity at 6 months, right? Now you're jumping to phase 3 treatment. So at this point of time, the recommendation is, right, try to switch between the biologicals or the targeted synthetic DMARDs. Like TNF alpha, maybe you can give up and start with an abatacept, or maybe you can add the anti CD20 drugs like rituximab, or maybe you can introduce baricitinib. So it is like a bit of trial and error, because developing guidelines in such a situation where your even biologicals or targeted specific DMARDs have failed is a bit difficult, right? So you just try to see what works for the patient and continue or stick to that, right? That's a phase 3 approach. So this is how we approach a case of rheumatoid arthritis, right? So that is the basic summary I want you to remember. So I think we have addressed most of the important MCQ points from this topic, and with that I am signing off, guys. Wishing you all the best for the upcoming NEET examination, And I would urge you to also spend some time on the MCQ discussion videos, because we convey a lot of points in these videos and it is really difficult for most of the students to remember all of that stuff. But when you try to solve or go through the MCQs, right, the points that are conveyed in the videos, or if you're a textbook person and you read books, it starts getting cemented in your brain, right? So please don't miss on the MCQ masterclasses. And even prior to the launch of MCQ masterclasses, there are a lot of my MCQ videos which I've already covered parallel to some of the text topics. So please go through them. Okay. See you guys. All the best.